Welcome back to my channel for another video. Chest pain, though it's quite common in children, luckily it is often not due to a life-threatening disease unlike in adults. But it can cause a lot of anxiety in children and parents. It can also cause absenteeism from school and studies. In that way, even though chest pain may not mean a serious disease like myocardial infarction, in children it has its own due importance, and a good differential diagnosis is very ideal. A detailed history and a meticulous physical examination is important as in any other situation in medicine or pediatrics. Suppose there is a history of lifting heavy objects or a lot of aerobic exercise and comes with chest pain, it could be related to muscular pain or skeletal pain. During physical examination, eliciting local tenderness may be a good sign, like in costochondritis or muscular pain. Suppose excessive movement of the arm has caused the pain, it may be in the pectoral muscle, and the muscle may be tender on examination. So in that way, physical examination and a good history will make out some of the causes of chest pain in children. Stress and anxiety, often school or study related, is an important cause of chest pain in children. But please note that before you attribute a pain to just anxiety or stress, other organic causes have to be ruled out by detailed examination. Otherwise, you may miss an important diagnosis. Chest pain due to organic disease may also be worsened by stress and anxiety. So all these parameters should be considered before labeling it as just due to stress. Then stress and anxiety is also eminently treatable by appropriate counseling. In the history, nature of pain will give a hint to the diagnosis. For example, in pleurisy, on deep inspiration, a catching pain will tell you that it's the pleural involvement. And in pleural effusion, it may be felt as a heaviness, and there will be associated shortness of breath, and it can be made out by percussion. Dullness can be made out and can be clearly seen by ultrasound and X-ray also. But in children, we would prefer to have ultrasound rather than chest X-ray, even though our old teaching was chest X-ray. Now more and more ultrasound is relied on for diagnosis of pleural effusion in children. It's easy to diagnose because there's a lot of difference between the density of the lung and fluid on ultrasound. So it's not difficult to make out. Reflux esophagitis with burning central chest pain is something which can be often mistaken for cardiac ailment in adults. In children it's less common but still can occur. Gastroesophageal reflux of acid can cause retrosternal pain, burning discomfort. Pericarditis is an important cardiac cause of chest pain in children. It can occur along with viral illness, and it may be relieved. The pain may be relieved by sitting and leaning forwards, and there could be some respiratory change also because associated inflammation of pleura can be there. One characteristic symptom of pericarditis is odynophagia while swallowing, because posterior pericardium is very near the esophagus. When the bolus passes through the esophagus, there could be increase in pain. That is odynophagia in pericarditis. Characteristic physical finding in pericarditis is of course the pericardial rub, superficial scratchy sound, which is triphasic, systolic, diastolic and late diastolic or atrial systolic events are heard in pericarditis. But all the phases may not be heard always. And pericarditis, the pericardial rub is known to be evanescent. It may be present certain times while it may not be present at other times. So you have to be looking at multiple times. Then only it might be picked up sometimes. But most often it is a rough, very loud superficial sound in pericardial rub. Then when pericardial effusion develops, rub may disappear and a person may go in for cardiac tamponade if it is severe with hypotension. Then it may be a quiet precordium. It can be easily made out by ultrasound, and aspiration also can be by ultrasound or echocardiographic guidance. Coronary artery disease and myocardial infarction are not unknown in children. That can occur due to congenital anomalies like abnormal origin of coronary arteries. Instead of arising from the aorta, it may arise from the pulmonary artery, that is Alcapa. And as an acquired form, there is Kawasaki disease, mucocutaneous lymph node syndrome. Kawasaki disease is fairly common in this region. Several cases are being diagnosed, and early diagnosis is useful because treatment by IVIG or immunoglobulin is useful. The disadvantage of delaying treatment is that there is more chance for development of coronary involvement. Coronary involvement can present later as myocardial infarction or aneurysm of the coronary arteries. And it is mandatory to have serial echocardiograms to assess the coronary arteries. In echo, in children especially, as the echo window is good, chest wall thickness is lesser, proximal coronary arteries can be imaged by echocardiography. And you should compare the dimensions of the main arteries to a nomogram to say whether the coronary arteries are dilated or not. It need not be always aneurysmal in the beginning. The dimension will be more than the nomogram. That's how you look for cardiac involvement or coronary involvement in Kawasaki disease. It need not be present in all cases, but some cases may have, and the presentation may be delayed also. In older children, more often in females, mitral valve prolapse may be a cause of chest pain as well as anxiety. There is association of anxiety with mitral valve prolapse syndrome as well. And hypertrophic cardiomyopathy in genetically determined cases can also present with chest pain. But those are all in older age group because most often the hypertrophy takes time to develop. So if father or mother is having hypertrophic cardiomyopathy, just doing an ECG and echo in a younger child and saying that the child does not have genetically determined hypertrophic cardiomyopathy may not be correct. It may be beyond adolescence that the hypertrophy is seen on ECG or echocardiogram. Serial evaluation may be needed. Another important cause of chest pain in older children probably is disease of the aorta. Aortic aneurysms can cause chest pain, and it is more likely to be in those with Marfan syndrome, tall, lean individuals. They are the persons who are likely to develop aortic aneurysm, and there is a predisposition for dissection also, but all these things are much later in life most often rather than in children. Another important cause or rather condition which should not be forgotten is tachyarrhythmias. Sometimes children may say the feeling of tachyarrhythmia, that is actually palpitation, but they may feel it as a chest discomfort, or younger children may not be able to differentiate between palpitation and chest discomfort. So that also is another cause for differential diagnosis in evaluation of chest pain in children. Tachyarrhythmia, supraventricular tachycardias. In children, most often supraventricular tachycardia is due to atrioventricular reentrant tachycardia, like in WPW syndrome or those with accessory pathways. In adults, more common cause of supraventricular tachycardia is atrioventricular nodal reentrant tachycardia, AVNRT. Accessory pathways are less common. compared to in children, percentage wise. In children, AVNRT or atrioventricular nodal reentrant tachycardia is less common, and most often it is accessory pathway mediated tachycardia. The reason is that as time passes, age advances, the ventricular insertion of accessory pathways can get fibrosed and accessory pathway conduction may disappear. That's why in adults, atrioventricular nodal reentrant tachycardia is more common than atrioventricular reentrant tachycardia mediated by accessory pathway. In children, that is more common. So we have an outline of important causes of chest pain in children. The key is good history and physical examination, followed by relevant investigations. Especially in children, we have to minimize the investigations because it is traumatic for the children, and many investigations which we can do easily in adults may be more difficult. For example, to get an ECG, you have to sedate the child or wait for natural sleep. Same is for echocardiography and other investigations. So getting investigations done in children needs a little more tactic.